Kate Woodworth is a pediatrician and medical officer on the emerging threats team. She's in the Division of Birth Defects and Infant Disorders at the US CDC. Thank you so much, Dr. Woodworth, for joining us today and presenting on this surveillance network, some of the data that's already coming in and some of the data that we could potentially look forward to in the future. Pass it over to you. Thank you so much.
Great, thank you so much, and really excited to be part of this presentation panel. And it's great to hear about all the amazing research. And I think my talk, like Dr. Gupta mentioned, is really going to focus around a little bit more around surveillance and epi in this population and sort of opportunities for treatment. So I'm going to try to go quickly here, but I did want to give a little bit of background. So I'm going to present about our surveillance for emerging threats to pregnant people and infant network. And so this is really a surveillance approach that was born out of the Zika epidemic, when we realized we needed to better address the issue that a lot of our national surveillance is really event-based at diagnosis. And what we need is information among mother-baby linked longitudinal surveillance. So really to be able to assess outcomes longitudinally in this population. And so while hepatitis C is a nationally notifiable condition, we know that surveillance has been under-resourced even before the strains of the pandemic. And in general, it's really challenging to get information about pregnancy status, let alone pregnancy outcomes, international surveillance. And so that's why we set up this sort of enhanced surveillance to look at these pregnancy-related conditions. And this surveillance network looks at multiple exposures, including hepatitis C, but we also fund jurisdictions to look at syphilis, COVID, and also CMV. And so our main partners are state and local health departments. And on this map, you can see those that we fund to do this hepatitis C enhanced surveillance. Within our surveillance networks, our inclusion criteria is pregnant people who have at least one positive HCV RNA test during pregnancy, or up to 1 year prior to pregnancy without any evidence of clearance or treatment. And then we automatically follow any of the infants or children from that pregnancy. Additionally, we also ascertain cases where infants or children are meeting the CST case definition for perinatal hepatitis C, which is here, and then enroll their birth parents. But I would say we have very few cases where that's how we're identifying the dyad. And then we're focusing on births that are occurring 2018 to 2021 for this surveillance efforts. And then I wanted to describe for this group a little bit more about our case ascertainment and data sources. Again, this being surveillance data. So here are 4 data sets that we collect. So we have a maternal data set with information about the pregnant person and their pregnancy, a birth data set with information about the pregnancy outcome, an infant at the time of birth, and then also an infant follow-up data set. And this includes information about the child's health up to 2 years of age. And then we also have a lab data set that includes all hepatitis C labs for moms and babies. And the main way our jurisdictions ascertain cases is through linkages of existing data sources at the health department. And so primarily linking these nationally notifiable positive hepatitis C testing results with birth certificates and fetal death records to sort of determine if that positive hepatitis C result came from a person who was pregnant at the time. And so as you can imagine, this ends up being primarily retrospective identification, since the outcome needs to have occurred for these cases to be reported. And so our jurisdictions collect information regarding pregnancy and outcomes from vital records and primarily the birth hospitalization records. And then the infant follow-up data comes primarily from the primary care provider medical records. Jurisdictions use a variety of methods to ascertain who these providers are in terms of doing this infant follow-up piece, from reports on the birth certificate of who the child's going to follow up with, to newborn screening data and what providers are receiving that, and also linkages of immunization records to find out where are these infants getting their 12-month vaccines from and going to those primary care providers. But all of this information is coming from existing data sources. So there's no primary data collection. There's not interviews with these pregnant people, for example. Real quick, this is just a snapshot of the variables we collect, the data elements. So for all of SetNet, we have what we call general variables, information you'd want to know about any pregnancy, regardless of the exposure. And then we also have modular variables for our jurisdictions doing this hepatitis C surveillance. So things like, was the provider or was the person treated for hepatitis C during pregnancy? Things like substance use, diagnoses of the infant for neonatal abstinence syndrome, and hepatitis C testing. So I also wanted to share some preliminary data. We are still actively collecting this information, and we're in the very early phases of analysis and dissemination. Many of our jurisdictions have not yet completed that medical record abstraction. So in general, this data is preliminary and subject to change, but I wanted to share a little about our cohort and outcomes. So this is just showing demographics. This is data as of our December data submission, so December 2022. We have 3,725 pregnant people with outcomes that have been reported. And so, not surprisingly, similar to other presentations, even on this call, our cohort is primarily white, non-Hispanic, and we see a very high proportion of people with substance use reported during pregnancy. And then on the right, I also just wanted to highlight, when during pregnancy, these individuals are getting their positive HCV RNA results reported. And so while the majority are being tested during pregnancy, about a third did have that positive result prior to pregnancy. And then I know this group is particularly interested in treatment, and we do have a place to collect treatment. So I asked our analysts to pull some of our very preliminary numbers, which no one will be shocked to see are quite low. So I'll reiterate again that jurisdictions are still completing medical record abstraction, so these numbers will change. So far, we've had about 89 cases that were reported to have received hepatitis C treatment, but we only have dates on 7 of those, and so we suspect that the vast majority of those are sort of historical treatment records that we're receiving. We're aware, I know we have cell suppression numbers for our data set, and so preliminary, I can't share the exact number. We have less than 5 that were reported to be treated during pregnancy, and those were all with DAAs. And so this is something that we'll continue to update as our jurisdictions continue to submit data. We expect numbers will still continue to be too low to make meaningful conclusions about outcomes after treatment during pregnancy, which is why we're really excited about this registry. But we do hope to be able to highlight opportunities for treatment with this sort of set-net approach. And on that vein, we also have started to look at how many people have had multiple pregnancies within our surveillance cohort. So this is not multiple gestation, but rather subsequent pregnancies impacted by hepatitis C, sort of highlighting, that there were missed opportunities for treatment and cure between pregnancies. And so this was an analysis done a little while ago, but overall 3% of people within our cohort have more than one pregnancy in our surveillance system. And again, this is just within that time window of 2018 to 2021. So if we had looked sort of broader than that, if we had a larger cohort, we might have had a higher number. But that means 99 people, had a missed opportunity between pregnancies to get treated. We also looked at some of the time between pregnancies. The vast majority had at least 3 months between their pregnancies, and half had, greater than 8 months. So trying to think about time to be treated with DAAs between their pregnancies, and trying to build in some time for breastfeeding as well. I didn't put it on the slide, but only about half of our cohort had initiated breastfeeding at delivery hospitalization. So as a pediatrician, I think that's a huge problem and something that we can, work on in this population, but also noting that for those who are not breastfeeding, again, that's removing one barrier to treatment. So again, something that we'll continue to update as more data rolls in. Real briefly, just wanted to throw out some information on some of the outcomes. Some of the things that we're interested in looking at is sort of highlighting adverse outcomes within this population. So again, vast majority of people reported substance use during pregnancy, primarily tobacco and illicit opioids. And then, within this population, we sort of see higher than you would expect in the general population in terms of adverse birth outcomes, like preterm birth, small for gestational age, NICU admissions, neonatal abstinence syndrome. So again, something that we hope to be able to dive into the data a little bit more to really stratify out some of those substance use versus sort of Hep C. And then I think the last data slide I had was just also highlighting, some of the infant data that we're getting Again, medical record abstraction is still ongoing, and so we aren't really we don't yet have all of the negative infant testing, but because it's a nationally notifiable condition, we have all of the positive tests that were done on the infants that have been reported. And so these numbers, really the takeaway is that of those infants that we would expect, so all of the infants born to people with hepatitis C in pregnancy, the health departments are only aware of about a third of the infants that we would expect to have perinatal hepatitis C to have been reported. And so just highlighting again, big issues with sort of lack of testing in these infants, but also something that we're really hoping to dive into more and flesh out more of some of the, reasons why or risk factors, characteristics associated with the sort of absence of testing or even inappropriate testing in the infants, which is something we see a lot of also. So last slide is just, there's a huge number of people involved in this surveillance across CDC, and also primarily I wanted to thank our state and local health departments. And then if there are questions, I'm happy to take them after this panel, but also here's our email for our Senate surveillance in general. So thank you.